Well, I have here with me Dr. Natalija Odanovic from Belgrade. You've been here before.
Yes.
And you're always very interested in reproducibility of the QFR.
Yes.
And by the way, you also have an appointment at Yale University and very frequent also endeavors and contacts and studies with the site. Dr. Shah, right?
Yes.
In particular. And you have tomorrow an abstract that is on the reproducibility of the QFR.
Yes.
That has been a topic for a couple of years now. And tomorrow is the presentation, but we like to get a peek, a peek preview of what you're going to present.
Well, as you know, like you said, I've been very interested in the reproducibility of all angio-FFRs, QFR included, and previously the publications like the QREP study showed that the reproducibility was not great. We would want it to be better. However, the previous studies were done in older versions of QFR software, and I've had the pleasure to experience the latest versions of QFR software, including QFR 3.0. And what I found is that many of the steps that were previously user-dependent have become completely user-non-dependent. They are now totally taken away from the users, and the AI behind the scenes is doing a really good job of like doing all the frame counting and reference selection and so forth. And then there are still steps that are user-supervised, like the contour correction, and that's where some user differences can arise from. And so I really wanted to give QFR 3.0 a stress test. So for the stress test, I asked medical students to help, because I figured if the medical students can do it, anyone can do it.
Okay.
And so I had 2 medical students do QFR analysis on 60 good quality angiograms. And I literally, they had no experience with coronary angiography, no experience with QFR. I had to sit down with them and make sure they knew which vessel was which vessel in each of the angiograms. Yeah. But once they figured out which vessel was which vessel, they did their QFR analysis. And I also did the QFR analysis myself. And I looked at the correlation between what I did and what the medical students did. And
Did they have any training or not?
So they did have to, they obviously had to undergo the vendor training, for the use of the software. But they don't know anything outside of that. They really are there mainly for image analysis. Yeah. And applying, obviously, all the strategies that you teach them during the vendor certification. Yeah. And that was enough for them to achieve almost identical results to what I was getting for my QFR analysis. Yeah. So we were able to show really good reproducibility. We had, whereas in prior studies, when several observers were doing QFR and they could achieve binary agreement in maybe 50-something% of cases, we were able to do it in almost 90% of cases. Okay. And getting a big difference, like bigger than 0.10 between the lowest and the highest value, in our cohort, it was in less than 10% of cases. So only in 8% of cases we had some big differences. Otherwise, the values were pretty much very consistent between different observers. And
because I remember we have had some discussions in the past with earlier versions where you also did reproducibility. But now I'm very happy to hear that you are achieving now excellent results.
Yes.
And of course, the results always depend on image acquisition.
Yes.
Do you have the proper views? Do you have a proper the image quality in general? The contrast image, the vessel to background contrast, the contrast injection, all these have an impact on the results, and of course the user interaction. But you have taken now, it's the same acquisition, but it's really the user interaction that you are
that we were looking at, yes. And I have to say, admittedly, we did take only good quality angiograms because these are medical students after all, and I cannot expect them in some tricky angiograms where there is a lot of overlap to identify the vessel correctly. So I chose the angiograms that were good for analysis. So we did take that, variable out of the equation, if you will. Yeah. But we, if like I said, if people with no training or minimal training, just what's really the bare minimum, can do it, then that means that it might be more broadly applicable in the cath lab. It means that maybe your tech or your nurse can help you do it while you're with the patient, and
Yeah.
it can be more widely incorporated.
Yeah.
And certainly it matters that even if different interventional cardiologists are doing it, that we're all getting the same results.
Yeah, and that was also one of your issues that you want in your interventional cardiology team. You want everybody to provide the same quality, actually.
Right. And as you know, the sub-study from Favor, Europe, Japan, we know that once the core lab analyzed what was done in the real life in the cath lab, they got different results, quite different, because they introduced more correction points and they, did things differently, and that led to discrepancies in whether something was a positive or a negative QFR and how that was ultimately treated in the patients. And so it's really important that we can get everybody to achieve the core lab level, but with no specific, or rather without the core lab training.
Sure.
Because we can all be core lab
but of
trained.
course we will always provide a basic online training for the user.
And that's what our medical students did as well, and that was enough for them.
And that is also a very clear result, that online training is sufficient, because you got excellent results on good quality images.
Yes.
What we saw in the Favor 3, of course, if you take out the poor quality data sets, then of course you also get a MACE value that is much lower than what we achieve now. So it matters really if you have not only perfect images, but if you have sufficient quality data sets, then you will get a good results with the QFR.
Yes. So I'm very happy to see that the development of the software is going in the direction of ensuring good quality images and kind of streamlining that process from that.
And you get also a signal whether if a particular run is not good enough.
Yes.
We provide an image quality assessment also, so that you can always redo the case or that particular projection and then come up with a better run.
Yes.
So that's really very helpful and fantastic that you did that study. Are you going to publish about that? This is an abstract?
So this is an abstract, it's a pilot study. I'm aiming to get, it's really a sub-study of what I want to do. It's just a little demonstration, but I want to repeat the QREP study, and that's what I call it. I call it Q-repeat, because I think it needs to be repeated. So we are looking at having 5 interventional cardiologists do the analysis in the same cohort of patients, and then see how well their findings agree.
And what is the timeline for that? busy interventional.
Busy timeline, yes. It depends mostly on my colleagues when they will get to do the analysis. So I can't give a definitive answer.
Sure, I understand that. But it's really great, and we look forward to hear your presentation also tomorrow, and that you have been making great progress. So we'll certainly keep in touch, and you see that 3.1, we have made the next step in automation, and we continue to do that, of course, to make it really simple and automated and fast also.
Yes.
So, fantastic. Natalija, thank you so
very
much. It was a pleasure having you here.
Take care.